Thank you, Professor Stanka, for the kind words. As you said, we are here to share and to learn, and we learn from our experience. And I will share our humble experience with a few patients with Vabysmo. I also want to thank to Roche for having me here presenting our preliminary experience with Vabysmo. So, is it a confirmation of the change of how we treat our patients or not? Probably after our presentations, we will ask you that question. Would you gonna change your approach in the presence of a new medication which might offer additional benefits against the inflammation and vascular leakage? So, in Euretina, they said, what you see is what you get. Is that the truth behind this statement? Obviously, Vabysmo was receiving FDA in 2022, and in September it received the European Commission approval. And the real-world experience seems to complement the results from the randomized controlled trials. What has happened in the past with well-known anti-VEGF agents that we used to apply to our patients is that sometimes there are discrepancies between the real-world experience and the clinical trials. It's not a problem, it's an opportunity to see how in the real world we might find a pattern of treatment which might be more beneficial for the patient or not, actually. So, Vabysmo is approved in more than 95 countries. 4 million doses are already distributed, and no significant or, let's say, different than the clinical trials adverse events were seen, which is really important. As stated by the previous speakers, there are real-world monitoring, let's say, trials, which are Roche-sponsored as a Voyager, Far Retina, Far Wide, and Passenger, but there are independent studies. In my presentation, I will also share details about the Turkey, which is independent studies, and it's a really powerful comparison between the industry-sponsored trial and independent one. Let's see if they coincide as conclusions or not. Real-world outcomes in the past sometimes deviated from the randomized controlled trials. Why? Because they are controlled trials. Everything should be specified and carried as per instruction. In the real world, there are socio-economic factors. There is a patient adherence. There are a lot of things which might affect how actually we are treating our patients. So I will talk about the Voyager study and what are the most important outputs. Obviously, the long-term effectiveness and safety of the drug. To gain the insights regarding the real-world treatment patterns and how they can change our treatment decisions. And last but not least, I think this is the most important thing, to identify key anatomical features, no matter if on OCT morphology or other imaging modality, things or signs which will lead us to the decision to extend the interval of the injections or to be more aggressive with the treatment. More than 5,000 patients, 28 countries, and it will be 5 years of observership, which will produce a lot of data which can guide us through modifying or accepting as a beneficial our strategy which was presented from the company. Here are the preliminary results which show what happens with the treatment-naive eyes, with the subretinal fluid and with the intraretinal fluid. After 6 months of faricimab treatment, there is a marked reduction of the supraretinal fluid and intraretinal fluid with the patients with AMD. What happens with the visual acuity? Obviously, it's gained, and plus 3.5 letters as visual acuity is something significant. And related to that, of course, we will have a reduction of the central subfield thickness, which is sign of anatomical recovery. The same applies for DME patients, and this is the percentage of the treatment-naive eyes with supraretinal and intraretinal fluid. On this slide, I want you to think a little bit between the lines. Why we have eyes with supraretinal fluid, and why the percentage is so low? We know that these are treatment-naive patients, so it's early stages of diabetic macular edema. We have supraretinal fluid only in advanced cases of diabetic macular edema, and we know that this is a treatment challenge. There is no anti-VEGF agent up to now which can influence the supraretinal fluid in advanced diabetic macular edema. What we did up to now, we are using triamcinolone alone because we assume that this is inflammation. Of course, and why that happens? Because the choroid is involved. The choroidal ischemia is additional, let's say, contributing factor. So here, with this slight remark, I want to say that there is a new treatment opportunity even in the advanced diabetic macular edema with Vabysmo. Of course, the visual acuity will increase when we have anatomical recovery. So the early takeaway messages from Voyager is actually we have visual improvements. 3.5 letters in AMD eyes and 7 letters in DME, which is significant. Anatomical improvements, early drying phenomenon. As in the previous presentation, we saw that it's the fastest drying drug that we might apply compared to other competitors in the anti-VEGF field. And the percentage of the eyes with supraretinal fluid and intraretinal fluid was lower at month 6 versus baseline. And last but not least, again, safety profile. No new safety concerns were identified compared to the clinical trials. This is the independent study, the Turkey, which tracks the changes and how is the follow-up in patients with AMD. And it is 2.5 years of length, meaning half of the Voyager. So it's a significant in terms of relativity to the questions. And you can see here that efficacy after 3 injections of faricimab in treatment-naive eyes will gain us plus 2.4 letters in visual acuity, and it will extend the interval of the injections to roughly 2 months. What happens with the switched patients? It is again beneficial, obviously with less extension of the period between the injection, and there is an explanation behind that. In order to switch a patient, obviously it's an advanced disease or a disease which is not well controlled with the current aflibercept treatment. So the starting point is a little bit different between the treatment-naive eyes and the switched patients. Efficacy after 9 injections of faricimab. Still, we have gaining in the treatment-naive patients with plus 3.575 letters and almost 3 months extension between the injections, which means that there is a continuous improvement and steady effect over the retinal anatomy, which leads also to improvement of function, 3.575 letters. And with the switched patient, we have extension, which is modest, but the functional outcome is not so remarkable. Why? Because the starting point is different. These are, let's say, end-stage eyes. In order to be switched to faricimab. The message for me is that we don't need to think for the faricimab as a second line of treatment or strategic treatment. It is not antibiotic to be saved for more tougher conditions. If we can start the patient as a primary therapy with faricimab, obviously the conclusion from the Turkey is that we gain more function and more anatomical recovery. Safety outcomes. As in any other medical application, it's normal to have adverse events. One of the most important is non-occlusive vasculitis. From almost more than 3,500 patients, there was only one case with bilateral non-occlusive vasculitis, which resolved with topical therapy and regained the baseline vision. It came out from the explanation from the authors that this was patient with systemic disease. So it's debatable if this is a problem of the drug or it is a problem of the body. What is important is that the safety profile is the same as seen in the Voyager, Far-Retina, and the others. So we have a merge between the results of industry-sponsored trial and the independent one. So powerful result. What are the conclusions? In the real-world setting, we have rapid improvement in the anatomical parameters and we have functional gains. The patients which are switched to faricimab from aflibercept had interval extension of almost 3 weeks. As I said, the functional gains are a little bit modest. Why I repeat this slide? Because it might explain why we have better results in the treatment-naive patients compared to the switched patients. In Tenaya and Lucerne, there was pooled aqueous humor samples and Ang2 levels were examined. After a single injection of faricimab, Ang2 levels were disappearing. After numerous injections of aflibercept, there was no change of the Ang2 levels. And of course, as a reminder, why it is important to control the Ang2 levels, because it supposedly stabilizes the vessels, reduces the vascular leakage, and reduces the inflammation. What is also important for faricimab compared to other, let's say, long molecules, is that it has a modified Fc fragment which reduces the systemic exposure, and in that terms it might be more hidden than our own immune responses, which are probably responsible for the vasculitis and such type of inflammatory adverse events. Multiple biomarkers have shown how the faricimab is actually working. Neovascularization, vascular leakage are attributes for elevated VEGF, but the vascular leakage is also attribute of the inflammation, which is related to the Ang2. So in the real world, treatment with faricimab shows significant visual function improvement, anatomical improvement, durability, which is depicted with the extension of the in-between injections intervals, and a good safety profile. So this is my first case. It's a male which is switched from Avastin and aflibercept, so it was last resort for him. And on the first picture here, you might see almost all the attributes of neovascular membrane and age-related macular degeneration. I want to stress your attention on these hyperreflective structures under the pigment epithelium. It's called sub-RPE cells accumulation. This is a sign of starting of a fibrosis. If you noticed, my colleagues also spoke about fibrosis inhibition. We know that in order to achieve this pattern, which might be assumed as outer retinal tubulation, it should be end stage. And when we see the outer retinal tubulations, we might assume that we lose the battle. Obviously, the outer retinal tubulations shouldn't be here, but they should be above the RPE. But anyways, it's a sign of fibrotic activity. This is after one injection of Vabysmo. This is follow-up 1 month. You see the durability of the effect. This is the follow-up after 3 months. So from a completely disastrous appearance, with a single injection, we have this appearance of the macula. Obviously, we need to identify here signs of regaining of activity in order to modify our approach. But believe it or not, this is an eye with function 0.7, and it's a single eye. So for me, it was saving the day, actually. This is a female patient. Again, we have RPE detachment, we have subretinal fluid, we have neurosensorial detachment, we have hyperreflective foci, and again, after one injection, we have this appearance of the macula. What happens after 1 month, after the second month? Again, the disease is regaining or it's attacking us. So the previous case and this one are here to emphasize that we need to regularly check our patients, because we cannot rely on this 3 months extension of period in every patient, because we still need to learn a lot about disease progression and activity. And this is the last case, female. She was switched to Vabysmo, again because there was no response with the regular anti-VEGFs. And here, after one injection, this is the result. This is 2 months follow-up, and she is stable. You see, there is a reduced activity under RPE, again in supporting the claim that there is a reduction of fibrotic processes. And this is 2.5 months stable with a single injection. All that examples are showing that we need to have established criteria, especially for AMD, also for DME, but here it's depicted the proposed criteria for how we modify our treatment. No best corrected visual acuity loss, no central subfield thickness increase, and no new macular hemorrhage. We extend the dosage. If we see one of these BCVA loss, CST increase, and especially new hemorrhages, we need to reduce the dosage interval. So, thank you.